Hello, friends. Welcome to our 11th session of She and Rights Live from Women Deliver Conference 2026 on the theme Ending AIDS in Anti-Rights and Anti-Gender Era. She and Rights Live at the Women Deliver Conference 2026 sessions are being hosted at D03 Exhibition Space in Narrm, Melbourne, Australia. All sessions are hybrid, live streamed, and host online and on-site speakers and participants, including media. This She and Rights session, live at Women Deliver, is co-hosted by Global Center for Health Diplomacy and Inclusion, or CEHIDI in Switzerland, Geneva, and CNS with partners like Women Deliver Conference 2026, International Planned Parenthood Federation, IPPF, Asia Pacific Resource and Research Center for Women, or ARROW, Asia Pacific Media Alliance for Health, Gender and Development Justice, APCAT Media, and Health TV Online, Nepal. Hello. So let me, going forward, this session will explore the impact of anti-rights and anti-gender pushbacks on the health responses, especially HIV. The promise by all world leaders was to end AIDS by 2030, which means all people living with HIV or should be on life-saving antiretroviral therapy and remain virally suppressed so that they remain healthy and virus stops spreading. The World Health Organization says that there is zero risk of HIV spread if a person's viral load is undetectable. Undetectable equals untransmittable. Ending AIDS means zero new HIV infections and zero AIDS-related deaths. But those impacted by anti-rights and anti-gender pushbacks and related funding cuts, for example, such as girls and women and gender diverse communities, are also vulnerable to infections like HIV. Gender equality, or SDG 5 goal, is a bedrock to progress towards goals and targets like SDG 3, which is on health and well-being, or ending AIDS. But ground reality stands in stark contrast to this. Over 1.3 million people got newly infected with HIV in 2024 worldwide, and 630,000 died of AIDS-related causes in 2024. No one should be getting newly infected with HIV. No one should be dying of AIDS-related causes, given the science-based tools and approaches we have today. So without any further ado, we already have our Rena joining us from Thailand. So welcome, Rena. Rena I'll come to her, but first we need to listen to Tariro Kutadza. So thanks a lot, Rena, for joining us. We have a huge respect for your Tangerine Community Clinic and the work which IHRI has done with the years. So, however, let us listen from our opening speaker first, my friend and sister from Zimbabwe, Tariro Kutadza, who leads on advocacy, communication, and social mobilization for Zimbabwe National Network of People Living with HIV, or ZNNP+, and is also the founder, national coordinator of TB People Zimbabwe. So, over to you, Tariro.
Good morning, good afternoon, good evening, and thank you for the opportunity to speak today. My name is Tariro Kutadza. I'm an HIV/TB advocate from Zimbabwe. I bring you greetings from sub-Saharan Africa, a region carrying the highest burden of HIV and TB, but also home to some of the strongest community-led responses in the world. I speak not only as a practitioner, but as a woman who has experienced the realities we often discuss in policy spaces. I want to start with something I have experienced, not once, more than once. Sitting in a boardroom, contributing to decisions that affect thousands of lives, and still feeling like my voice is questioned or quietly set aside. Not because I lack expertise, but because I am a woman. We are at a defining moment. We already have the tools to end AIDS. We know what works, but at the same time, we are facing growing backlash against rights, against gender equality, and against communities. This is not an abstract. It is shaping who gets care and who gets left behind. There is no pathway to ending AIDS without gender equality, and no pathway to ending TB without addressing inequality. We often say stigma is at the grassroots, but stigma also is in boardrooms, workplaces, and decision-making spaces. As a woman in leadership, we experience it in silence, doubt, and exclusion. And yet, communities are moving ahead. So I keep asking myself, why are our systems slower than the people they meant to save? In sub-Saharan Africa, young women remain most affected by HIV and TB, and TB remains the leading cause of death among people living with HIV and AIDS. These are not just medical issues, they are outcomes of inequality. But there is hope. Communities are leading. Every day, we must defend rights without compromise. We must send gender equality. We must integrate HIV and TB services. We must invest in community leadership. And we must confront stigma everywhere it exists. Because epidemics follow inequality. HIV exists at the intersection of health and social justice, but they can also follow courage. We must not only scale up treatment, we must scale up justice. And we will not end these epidemics in a world that denies women power, whether in communities or in boardrooms. I thank you.
Thank you so much, Tariro. Thank you. It was really great that you have also connected the dots between TB and HIV, and no doubt about it that it is the injustices and inequalities in our society that have put people more at risk of not only TB and HIV, but also these are big access barriers for existing services. So thank you for putting that spotlight. So now let me introduce our next speaker, our big inspiration from Land of Smile, Thailand. Rena Janamnuaysook is a transgender woman who serves as program manager for implementation science at Institute for HIV Research and Innovation, and globally known for Tangerine Community Clinic of Thailand. Welcome, Rena. You friends, you must have heard Rena before. She's a big inspiration to a lot of people, and also the work which IHRI has done is really is in itself a benchmark for advancing community-led service delivery model, a key population-led service delivery model, which is so critical if we are to end AIDS. Welcome, Rena. Over to you.
Thank you so much, the moderator, for introducing me and for giving me this opportunity to speak. I don't know if you can hear me okay.
Yes, Rena, we can hear you okay, loud and clear, and see your slides as well. Thank you.
Okay, that's brilliant. Thank you so much. And my special thanks to the organizing committee for giving me this opportunity to speak. So as suggested by Shoba and Bobby, I was assigned to talk about how the Tangerine Clinic, which is the transgender-led health clinic based in Thailand, we have struggling in the past years due to the recent funding cuts, as well as the anti-rights and anti-genders era. And I will share a little bit about how we have achieved by using the evidence to advocate for the policy change in Thailand. And I will use my next 10 minutes to show how we have addressed these challenges. So And the outline of my talk, I will talk a little bit about how and why the Tangerine Clinic was created and what's happening during the US funding cuts, and how we have used the data from the community collected evidence to advocate for the policy change in Thailand, especially to be included under the universal health coverage. And historically, I think as you may have already known, transgender women, specifically, we were categorized under gay men and other men who have sex with men umbrella in HIV and AIDS response many years ago. And there's some misconception from the policymakers. They view gender affirming care as a cosmetic after the essential healthcare or the rights to health among trans and gender diverse population. And that's why the consequence is that lots of transgender people or community members, they rely on self-medication when it comes to gender affirming care. And in terms of HIV and other sexually transmitted infection, it's really showing the high disease burden in this area. And that's why back in 2015, we established the first transgender-led community health clinic in Thailand by integrating gender-affirming care, especially in terms of hormone therapy and hormone level monitoring, together with the sexual health and other essential health services identified by members of the transgender community. So in this case, we have included or integrated mental health care into this service provision as well. So the Tangerine Clinic is a one-stop shop clinic founded in 2015, located in the Institute of HIV Research and Innovation, or IHRI. And the strength of the Tangerine Clinic is that the clinic is led by a trained transgender personnel, including transgender counselors, nurses, and physicians as well, to ensure that we will have no judgmental or stigma-free clinic environment. And this shows you about how the Tangerine Clinic has served trans and gender diverse communities in the past 10 years. So you can see in orange color above, you can see that as of 2024, the Tangerine Clinic has served more than 7,000 of transgender individuals. And on your right-hand side, you can see that more than 90%, they are identified themselves in a transgender feminine or transgender women. And the HIV testing uptake in the middle in green was almost 90%. And for those who tested negative or tested without HIV, we were able to link them to HIV pre-exposure prophylaxis or HIV post-exposure prophylaxis according to their sexual risk behavior. And moving on your left, in purple, you can see that the clinic were able to diagnose 8% of transgender clients, they living with HIV. And of those who living with HIV, we were able to link 95% of them on antiretroviral treatment. And most of them initiated treatment on the same day of HIV diagnosis. And of those who on antiretroviral treatment, we 96% of them, they have successfully have viral load suppression. And you can see that in terms of sexually transmitted infection, for example, syphilis, chlamydia, and gonorrhea, we were able to test them, to link them to STI testing, and we were able to link them for STI treatment as well. So and we also analyzed our data in the transgender cohort at the Tangerine Clinic. We found that by using gender affirming care, especially hormone treatment, is able to link transgender individual, especially trans women, to other HIV prevention care and treatment services. So we analyze the data, and it's showing that by using gender affirming care as an entry point, we found that most transgender women, they were likely to come back for the subsequent clinic visit, they were likely to have repeat HIV testing, as well as they were likely to initiate PrEP or HIV pre-exposure prophylaxis at our Tangerine clinic. So we develop a visual design showing that using gender affirming care is able to build trust and engagement among transgender individuals, and then we were able to link them to other HIV prevention and care services as well. And this data shows you about the bending of the curve on HIV infection. So we also observed that in the during 2016 to 2019, we observed that the decrease new HIV infection rate among the transgender individuals who visited the Tangerine clinic. So it's really showing that we really successful in bringing down the HIV epidemic among the transgender people who are visiting or using the services at the Tangerine clinic. And for those who on ART, we were able to achieve viral load suppression as well. But however, last year, at the beginning of last year in 2025, we received the funding cuts, as most of the fundings of the Tangerine clinic actually came from the US government, and we also experienced anti-rights and anti-gender stigma, as well as the discrimination as well. So this slide shows you about the data we compare between 2024, which was right before the US funding cut, and then in 2025 when we experienced the US funding cut. So you can see on your right hand side that the data show the immediate fallout in different kind of HIV and related services among transgender individuals who visited the Tangerine clinic. So we found 28% was reduced in HIV testing, 45% was reduced in PrEP initiation among new PrEP users. And then we also experienced 50% or half of the syphilis testing among transgender women at the Tangerine clinic, and 32% of them, they had reduced in hormone level monitoring. So it's really showing that when the anti-rights and anti-genders situation hit the Tangerine clinic, as well as the international funding decrease, we also experienced the service the low service uptake among the trans and gender diverse population at my clinic. So this is slide show you how we have addressed to this problem. We also learned that relying on or depending on international donor is not the sustainable way of providing the services to the transgender communities in Thailand. So we prepare to use the 10 years of the community collected data at the Tangerine clinic, including the cost analysis and implementation evidence from the Tangerine clinic and other civil society organizations. And we presented this data to the National Health Security Office, or NHSO, which is the healthcare service payer in Thailand, and together with the advocacy from the right-based and civil society organization in the country, and to present this data to the organization or NHSO, and all of these data were presented to the different national stakeholders and policymakers in Thailand. And the decision was made in 2023 that the NHSO approved the gender affirming care as well as the hormone treatment for trans and gender diverse population to be included under the universal health coverage. And in 2025, the government also put aside the specific budget for gender affirming care, which was around $4 million to support the gender affirming care under the universal health coverage. And this slide shows you how the process has been prepared after the announcement of the inclusion of the gender affirming care under the universal health coverage. So we in the past year we have prepared for the procurement, and SSO established the National hormone procurement system to ensure supply chain stability. And in terms of the service standard, we also work with the National Health Security Office and the Healthcare Professional Association to develop the gender affirming care clinical protocol, and it's also comes to the approval already. And the NHSO also set up the reimbursement mechanisms for the civil society organization to be able to reimburse for the service fees from the National Security Health Office for the gender affirming care after we experienced the US funding cut last year. So right now it means that civil society organization in Thailand who are providing gender affirming care, especially hormone treatment, they would be able to reimburse for these service fees from the government. And then they can provide these services to the transgender individual or transgender communities at their own provinces or their own area. But the rollout or the implementation of these services will be taken place in June, hopefully. And right now, the Tangerine Clinic, we also strengthen the capacity of the healthcare providers as well as the community health workers to be able to provide gender affirming care services as well. So in conclusion, we learned that from our implementation experience in the past 10 years, we learned that gender affirming care is not ancillary to HIV services, but it strengthens testing, PrEP uptake, retention, and continuity across the HIV cascade. And we also learned that abrupt funding withdrawal actually disrupted the prevention and treatment of HIV services. So sustainable HIV responses require integration into the national financing mechanisms and system. And lastly, when the community-generated data are rigorous and strategically translated, they can reshape the national policy and institutionalize the equity within the healthcare system in our country. And I would like to acknowledge all the support and contribution from these academic institution, governments, authority, as well as the civil society organization for having made the gender affirming care policy possible in the country. Thank you very much.
Sorry, I was on mute. So Rena, Janamnuaysook, thank you so much for this powerful presentation. It's a very important piece of work. It has shown that the impact, and we really hope that this takes center stage as we move forward. There is no doubt about it that the evidence which and the experience and the learnings from Tangerine Community Clinic, for example, and other key population-led service delivery models should be the guiding light as we move forward. The best time to do things like Tangerine Community Clinic, Rena, was yesterday, but the next best time is today. So let us not miss this opportunity. So thank you again, Rena. Without any further ado, let me move forward and invite our last speaker today, Dr. Trupti Gilada. Dr. Trupti Gilada is a senior noted infectious disease expert, and she works at India's most comprehensive HIV-related center in Mumbai, Unison Medicare and Research Center. She also consults in several other hospitals there, and also serves as the Joint Secretary of AIDS Society of India. So welcome, Dr. Trupti Gilada. Thanks a lot for joining us today from Mumbai. Over to you.
Good afternoon, everyone. First of all, thank you so much for this invite to join you on this She and Rights campaign and talk about just women's rights and where women stand in this entire fight against HIV/AIDS. As we approach 2030, we often say that we now have the tools to end AIDS. Effective ART, PrEP, U is equal to U, better diagnostics. But yet, when we look beyond science into the real world practice, the picture is far more complex. Ending AIDS today is not just a biomedical challenge. It's a structural challenge. It's a social challenge. And it's deeply, deeply gendered, unfortunately. We talk about a lot of these developments that we've made, be it ART, be it PrEP. But the challenge is, where are we actually standing when we talk about access to these things for women, especially for younger women? We are living in a time where scientific progress has not translated equally into access. We have the prevention tools and the treatment tools, but the access remains uneven. And this equity is most visible when we look at women. Now, look at the numbers. Globally, over 40 million women are living with HIV. More than half, about 53%, are women and girls. And when we look at sub-Saharan Africa, it's even more. In sub-Saharan Africa, it's around 63% newer HIV diagnoses are in women. When we talk about adolescents, about 90% are in girls. So women are really underrepresented, be it access, be it clinical trials, be it studies, be it research. PrEP uptake among women globally remains low, often less than 1/3. So it's not really failure of science. It's really failure of how we deliver these aspects into our healthcare. And this gap really widens further in an anti-rights, anti-gender environment, where access is restricted, but the stigma persists, the autonomy is limited. We often say that women are not a subgroup in HIV. They are really central to this epidemic. And yet their realities are often invisible in how we design care. They are primary caregivers in most families. They're caring for kids, they're caring for elderly, they are caring for their partners. But when it comes to their own health, they are often the most neglected. There is the paradox. They are caregivers, but not primary earners. And because of that, their health becomes secondary. Be it access to testing, prevention, treatment, it's always determined by autonomy and not always by the availability. Because women don't often make decisions about their own health. Even when it comes to a lot of decisions, it's made by someone else. Even something as basic as consent is often done by the partner or someone else in the family. And I think that is where we need to bring about a change. That is where filling the gaps really starts with, is really we have to bring women, put the onus of their healthcare, give the responsibility and the rights to the women themselves. At least in our setup in India, it's not unheard of where women are still turned away when they test HIV positive. For example, when these pregnant women test positive for HIV, they are often turned away from healthcare settings. They are sent from one nursing home or clinic or hospital to the other to really find a setup where they will get stigma-free, very respectable care. And we see women turned away even for surgeries when they are found positive. So while we might talk about these developments and understanding of HIV in HIV caregivers or in activists, these subgroups, I think we need to take the information out there to surgeons, to gynecologists, to primary health caregivers, to even insurance systems. Insurance systems, especially here in India, they deny care directly or indirectly using HIV as a reason. So while the science has advanced, the benefits remain restricted, often limited to, like I said, HIV specialists and activist spaces and not fully integrated into mainstream healthcare. There is where the real gap lies. It's not in the knowledge, it's in the translation about how we've translated this into other caregivers. How have we translated this into policies? India has the HIV/AIDS Act of 2017, but the law sounds beautiful. It looks beautiful. It's progressive. It prohibits discrimination. And yet, there has not been one single formal complaint under this act. And the discrimination continues every single day. Patients are turned away, care is delayed. And we are left with this difficult truth that policies often exist on paper, but the implementation is weak. And that's where we really need to bring about a real change. If we are really serious about HIV, about ending HIV/AIDS, we need to rethink how we deliver care. I think first we need to integrate HIV into routine healthcare. And it might sound very simple, but it has not happened. It remains like one separate vertical program about HIV and HIV/AIDS. Somewhere HIV/AIDS and STI is integrated. But when we talk about really integrating this care in women's healthcare, I think that is where it's lacking. And for this, we really need to rope in obstetricians, gynecologists, surgeons, primary health caregivers, in fact, all subspecialties of HIV, of medicine, to really understand that it's not one of those isolated illnesses. These are the same people who require other care as well for other illnesses. Second, I think we really must expand our access to prevention. PrEP must become part of mainstream care for women, not limited to specific populations, not isolating that access to certain cities or certain centers. We really need to make people aware that there is a tool for HIV prevention available, and these things need to be adapted, not just on paper, but not also in policy, but also really making it available through systems that do not discriminate against people who come and seek this. And third thing is we need to move forward and use social media tools just the way the young people are using. They are accessing a lot of their companionship or a lot of their sexual needs, a lot of casual sex on social media apps. I think that is where we really need to, as a community, need to move, where we can share messages, give awareness messages, talk to them about condom usage, PrEP, really allow women to navigate condom use themselves. And I think that is where we talk about really moving forward, just the way the times are moving forward, is using platforms and using tools that young people use. And I think fourth is really prioritizing adolescent and young women, because I think that's an entire subgroup that is completely left behind. And this is the future of tomorrow. And I think we really need to make it happen. Ending AIDS will not happen in HIV clinics alone. It will happen where women already seek care. And we often say we have science to end AIDS, and that is true. But science without access, without equity, without rights will not end epidemics. And let's bring women to the center of their care, of this care, because they are not just beneficiaries, they are decision makers. We need to believe that they are decision makers, and we have to give them the right as individuals, as equal participants in their own care. Because it's not just about the virus, it's about correcting equity, it's about really walking together forward. And let's do it together. Thank you so much.
Thank you so much, Dr. Trupti. I think there is no time for questions as we have the session has exceeded by 4 minutes already. So I will again like to thank Dr. Trupti, especially Rena, Janamnuaysook, and of course, Tariro Kutadza for bringing in such an important perspective into the mid-level conference in Australia. Thank you. All the best. Thank you. Thank you, Rena.